Joining us on the webinar today. We have a very nice program going forward, and we're very lucky to have two very exciting speakers with us today. The two speakers we have speaking for us today are Carl Alfelt. He's the Assistant Vice President of Quality and Performance Improvement from Center State Healthcare, formerly Director of Quality for the Employer Division of Behavioral Health and Assistant Director of Quality at Pennsylvania Hospital, the Institute. And Brian Dushek, who's the Manager of Financial Applications, formerly Senior Program Analyst at Center State Healthcare System. The agenda today, we're going to go back and forth a little bit. We're going to have Carl come in and speak about Center State's readmissions reduction initiative. And he's going to go through the process of kind of the setup for them, what they were looking to achieve. And then Brian's going to come in and talk a little bit about how the deployment from a technical perspective went, the types of issues and how they got over them that they saw. And then we're going to switch back to Carl, and he's going to talk a little bit about the results and how they use the system and the outputs therein. And then at the very, very end, we'll come on, we'll give you a little bit of a preview of some of the newer things that we're up to with the system. Without further ado, here's Carl.
Thank you, Bill. Center State Healthcare System, let me just give you a small description, is a healthcare system that is centered around a 282-bed community medical center. As you can see there, we are running close to 14,400 inpatient admissions when we exclude the newborns. Our outpatient visits are close to 156,000, and we're running in the neighborhood of 63,000 ED visits. We have a medical staff of 511 board-certified physicians. In addition, the reason we're a system, we also have a senior service group, 94-unit assisted living facility that's right across the street from the hospital. We also have on the grounds of the campus, we have a 123-bed skilled nursing facility known as the Manor. And contiguous to the grounds, we have a 430-unit continuous care retirement community referred to as Applewood Estates. We're also just recently become part of CMS-approved Central Jersey ACO. So that gives you some sense of the landscape, if you will. For fiscal year 13, we got the 0.95% penalty on our readmissions. Now, that translates for us around $600,000 a year, or $600,000 for that year. The challenges that we ran into with readmissions, and this is not just CHF or the readmissions that Medicare is looking at, but all readmissions, truthfully, is all the reporting information that we have had has been retrospective. I think you all suffer from the same issue of trying to look at core measures that happened 3 to 6 months ago and not being able to actually, they're not actionable. Our case management department was also focused primarily on utilization review. I guess you could say utilization review and discharge planning. Those were the two things that were going on with case management rather than concurrent case management. We were having difficulty identifying these patients. How do you know who you want to go after in terms of readmissions? Because the reality is that some of these folks are more likely to be readmitted than others. So that was a major issue for us, is to try and identify these folks. Because we were using pretty much only retrospective data, we weren't able to get any sense of the effectiveness of our initiatives. Plus the fact we were not able to really identify which initiatives we wanted to go after. If you're not really able to do real-time cause determination, you have a very hard time putting initiatives into place that are going to work, and you'll know they're working within a reasonable time frame. We also didn't really have the ability to look at the patient after discharge, even amongst our own, even within our own, with our own system. What we were planning and what we continue to work on is being able to identify the patients, the at-risk patients, in as close to real time as possible. That's incredibly important to be able to, when the patient's in the hospital, you have the opportunity to effect change right now. And again, that speaks to the idea of having real data right in front of you. We also needed to be able to have some model by which we looked at the risk of readmission. There are a number of different tools out there, but again, it's very burdensome unless it can be automated to some degree to actually identify the risk of the patient. So this lets us deploy our resources more effectively by going after those people that are high risk. We also wanted to be able to integrate this process with the current workflow that we have going on. There are a couple of areas where that's important. Number one, we have a limited number, as everybody does, limited number of case management staff available. We need to be able to make sure that what they're doing from the utilization standpoint, the discharge planning standpoint, coordinates well with looking at the readmission reduction efforts while they're in the hospital, so they're not having to jump from screen to screen to screen to try and find out who these folks are. The other piece of this is we're a Saurian facility, and we have what's known as the workflow engine. We're working very hard to develop workflows that are associated with the computer, and this helps us trigger those workflows for the individual cases. We wanted to be able to provide the stakeholders with information. It's very difficult without this kind of analytics to be able to talk to a group of people, be they the hospital-wide folks or when you're going to the board, to be able to talk to them, to give them some indication of what's going on across the continuum of care. That everybody wants to know, why are these people being readmitted? The other thing that we were looking very hard for was give us a direction. Which things are working and which things are not. And again, when you have a cycle time for change of 3 to 6 months, you can't really set up next steps and actions in a timely way. You begin to lose impetus, and it's a very difficult kind of change effort. Now, the Focus Analytics platform has done a lot for us in this regard. Using a proprietary algorithm, the system identifies the at-risk patients on admission. That's incredibly important for us. We need to be able to do that as soon as possible when that patient hits the door. We need to be planning for how do we avoid a readmission in this particular case, or if in fact they are somebody that has been readmitted in the past. The predictive algorithms give you that information. They're able to give you somebody, if in fact this person was not a readmission and they're a straight first-time admission, by using the predictive algorithms, you're able to determine whether or not this person is at risk or at how high a risk for readmission. And that gives us the ability to then deploy our resources in terms of the case management more effectively. One of the areas that has been very helpful for us is in the system we do have components built in, case management components, and such as basically it's checklisting sorts of things. For every CHF patient, you want to know, have in fact they had a determination of their left ventricular function. Has that been carried out? That's a reminder. It's a checklist. Yes, it has. No, it has not. And what are we going to do about it? There's also a nice notes section which lets us personalize each one of these, and we maintain that information. It also gives us the opportunity to take a look at what's going on with the patient post-hospitalization. Because one of the checklist pieces is, in fact, did we arrange for a patient to have a physician follow-up? One of the better strategies to avoid readmissions is getting that patient to their primary care or their cardiologist as soon as possible after discharge. This lets us track, did we do it, and how well did it function. It gives us a real-time feedback. You're not having to wait for CMS to grade you and say whether or not you've got good readmission data or not to make your changes. Now, that being said, I'm going to turn you over to Brian here, and he's going to talk to you about the intricacies of the computer end of this. Brian?
Thanks a lot, Carl. Actually, I thought we'd start out by giving you a feel for our technical landscape with regards to our clinical intelligence environment. As you can see, much like many other healthcare organizations, our environment was fragmented with many disparate tools and systems, some of which were not necessarily designed specifically for healthcare. As a result, at times it wasn't easy to get the right data to the right people to drive organizational initiatives. As our approach to BI became more evident, we were faced with several challenges in accessing our data effectively. For starters, we had multiple IT applications and systems. We're kind of a best-of-breed approach here at CentraState. And we've got an application portfolio that encompasses quite a mix of vendors and in-house applications. This kind of caused us to need data from multiple disparate sources. We need to set up feeds and code sets, all of which would require normalization and integration into our BI environment. So what we decided to do was to utilize the Siemens Decision Support System as our enterprise data warehouse. We were pretty fortunate that our EHR data from Soaring Clinicals integrated into that natively, but we had to begin to prioritize data from all the other source systems for which we needed to integrate with its data warehouse. As we got into that, we began to realize that not all of our data was in codified or a discrete format. A good example of that is radiology and cardiology results. We found that they were stored in a text format. We also found that we had some issues with data governance. Data is sometimes siloed here, much like at many other healthcare organizations. And we found that we had some reporting inconsistencies because data could be extracted for similar requirements from different systems, or sometimes by people that didn't necessarily understand the data that they might be accessing. And really this led to the potential to get different results for the same requirement. So as we kind of embarked on our BI strategy, we started out by looking to address high priority strategic organizational initiatives, and one of those was readmissions. With the help of the people over at SpectraMD, we began to put together our vision of what our environment should look like. We thought we'd extract and normalize data into the Siemens Decision Support System, which, like I said earlier, was our data warehouse of choice. This would feed the Focus Actionable Analytics platform, which in turn would make this data available in dashboard modules for presentation to our customers. And in the case of readmissions, that was our clinical quality team. Here at CentraState, we've got a very small staff devoted to BI right now. So really one of the greatest benefits of going with Focus was the expertise that the SpectraMD analysts brought to the table during implementation time. They worked with us to understand where our data gaps were. For instance, we realized that near real-time ADT data, which is what we'd have in our Siemens Decision Support System, wasn't going to be sufficient. our care coordinators needed real-time census information. Like I talked about earlier, our cardiology results, they weren't in a structured format, so that posed a challenge to us as well. And at the time we embarked on our implementation, claims data from our homegrown patient accounting system was not yet in the data warehouse. So out of that gap analysis became, what was our reality. We need custom real-time feeds. We'd also need the ability for our care coordinators to collect data that we weren't yet capturing in our data warehouse. And we need to continue to feed data from Siemens Decision Support System. Frankly, the flexibility of the Focus agent really enabled us to overcome a lot of these data integration challenges. And in doing so, it allowed us to meet our deadlines with, like I said, limited BI resources internally, and I believe we delivered some great value to the organization. So with that, I think I'll kind of turn it back over to Carl, and he can really kind of talk to you about the value that we were able to deliver.
Thanks, Brian. As everybody knows, the proof is in the pudding, and basically this is a striking example of what we've been able to do with these kind of analytics. We were able to drop our readmission rate, our CHF readmission rate, rather dramatically over a 6-month period, and it also, by side effect, allows us to drop our readmission penalty. So that was very promising for us and very helpful. What you're looking at is a case manager dashboard, and basically this is the tool as the case manager sees the case. These are dummy data, but they do demonstrate that we've got the patient identifier with the patient name. Now, the thing that's most important, and Brian alluded to this, is the fact that a case manager who's assigned to 5 North, for instance, or tele-unit, only receives the patients that are on 5 North. That was a major challenge. That's one of the things that Spectra MD and the folks from IT were able to handle for us, because initially we had dashboards that were getting everybody, and we were able to knock it down to the point that a case manager on a unit got only his or her patients. So that was dramatically helpful. You're going to find their admission date, the day since they were admitted last, and that last discharge date, so it gives you some sense of how long they've been out of the hospital. You get the attending physician as well as the working diagnosis. I think everybody's aware of the fact that CHF patients don't come in necessarily with a big sign saying, by the way, I have congestive heart failure. You have to identify that, and there are other disease states or comorbidities that can mimic heart failure or overlay the heart failure, those being pneumonia, COPD, and in some cases a person will have a MI and have CHF secondary to that. The biggie is the last column there, which gives you your readmission risk score, and this is based on the proprietary algorithm, but it gives that case manager a score and said this is somebody who actually is going to need more of your time than the other fellow who has a less likelihood to readmit. The case manager dashboards present, as I said, these work lists for the case manager. They focus on the at-risk patient and using those algorithms that put the patient in a priority list, if you will. So you know immediately who you're going to be needing to deal with more readily than others. It helps us be able to hand off these cases to either if the patient is going to be discharged directly to home, hand off to the PCP, or in some cases they go to subacute rehabilitation facilities such as our own, and this allows us to be able to hand off that information to the subacute facility or to the home care agency if that's the case. We're able to track the actions along the way. Now these are the ones that are hallmarks for the CMS core measure, but in addition there are areas that are just positive, appropriate sorts of things to do. We want to make sure that the patient has an appropriate med reconciliation. We want to make sure that the patient has the education about the drugs that they're going to be taking and their limitations. We also want to make sure that they do have, in fact, a physician visit arranged. Now, we use social workers. We have case managers and social workers. We use the social workers to a large degree to actually reach out and make those office visits. It's amazing that how much push there is behind a phone call from Central State calling to an office manager about getting a visit within 3 to 5 days. It's easier to do it that way than it is for the individual patient to be able to do that. The other piece that's very important is they're able to share comments in the text field. That text field, and if the patient in fact moves from one floor to the other, which they do, they will show up on that second person's work list, and they will have the notes for pass-on information from one case manager to the other. Now the CMO or the CQO, myself being the CQO and reporting to the CMO, we have a dashboard that's at a higher level that allows us to be able to identify the trends and then share them with the board. We have what's known as the QPC, Quality Patient Care Committee. It's a quality committee of our board, and they want to know exactly what's going on with these patients. This allows us to make those presentations in a timely way. We can even drill down in the data. Because prior to this, what we were doing was my secretary and I were doing this on a spreadsheet for every meeting. And just, incredibly difficult, time-consuming thing to do. As it stands here, I'm able to go to the meeting, plug in the computer, go to the website, and bang, it's there. And I have the information readily available, and it is very interactive as well. That's one of the most important parts, is we're actually able to interact with the data, and we're able to drill down while we're there on during the presentation. In addition, we have very in-depth, this is where you can drill down, you have in-depth information about individual cases. So we have the opportunity to take a look at what went well, what didn't go well, cases that may need other interventions. If you look at the one case where it says patient has severe disease, this is something we're seeing more and more of as CHF cases become chronic and eventually become, if you will, terminal. These are folks that aren't going to benefit, and perhaps they need a different methodology. Maybe they need to be looking into palliative care, or have we reached that point? But this gives us the information that we need to be able to make those kinds of decisions. And it's readily available. It's something that we're able to not only see for ourselves, but be able to show others. I think we've had a substantial ROI on this product. If nothing else, if it stand alone, we have a 50% reduction in our CHF readmission rate. So that by itself is pretty impressive. We've used this tool to be able to improve the care coordination across the continuum, from the hospital to the post-acute facilities to home care agencies. We have a strategic relationship with VNA of Central Jersey that they're able to access this same information. So we're able to share the information outside the hospital. We're also gives us a platform to be able to reach out and make the appointments for the patient. So it has helped us a lot in that regard. It certainly has improved our HCAP scores. One of the ones we all know and love is, do you have the help you need at home? And this gives us a platform to be able to identify that information. And it actually has had the benefit of increasing our scores in that regard. In terms of getting the whole hospital together on the same page, coordinated towards the patient, it has improved our enterprise-wide integration. And by enterprise, I'm looking just at the hospital at this point, but it's able to provide a platform where everybody throughout the hospital is able to look at the same case and understand what's going on with that patient. It helps us identify the high utilization patients on admission. We know these are the high utilizers. These are the high cost patients that come in, and we know that they are at greater risk for readmission. We were able to take a workforce and reorient it. We were able to take our case managers, social worker group, and be able to orient them to not only the utilization review, the basic bread and butter, getting the bills paid, but coordinating the care. So much so that we no longer call them case managers, we refer to them as care coordinators. So that was a spin-off of this reorientation, because they're actually working directly to coordinate the care of the patient. It also gave time frame. It allowed greater time for them to be putting into caring for the patients who were at the greatest risk. And it also is giving us a common platform to follow up the patients outside the hospital. So overall, it's been a dramatic improvement for us, and it's been an incredible tool. That being said, I'm going to hand this off to Bill, and he'll talk to you about what's coming up next.
Thanks so much, Carl. Okay, folks, we have reached the end of the readmission section, but we're going to do just 2 more slides to give you a quick look at some of the other things that the Focus platform has up its sleeve. We have a significant amount of competency in understanding predictive analytics, in the collection of data, the calculations of measures, and of course the presentation of all this information in a web-based system. So the next steps for us, and the next steps that our hospitals typically take after they look at the readmission systems, is looking at expansion of other types of chronic diseases. Other things that they start taking a look at is, you've done such a good job for me on the readmission side. We're looking at our value-based purchasing and core measure scores. What can you do for us there? And if you're doing measures, we have this MU2 attestation coming up. We'd love to be able to submit e-measures for these things. And I'm going to give you a little bit of a look right after this of what we're doing for core measures. And these tools are all really, once you have that core integration for the ambulatory side, ACO, clinical quality measures, disease registries, population health management, those areas are clearly areas where we have the kind of capabilities our customers are looking for, particularly on the ACO side of the quality measures area. So let me give you a quick look as to what we're doing in some of these areas, and I'm going to focus right now, just one slide here, on our concurrent core measures product. So what you see here is the dashboard, and what it's going to do is, on the far right side, you see core measure conditions in gray with the black writing. There are a series of colors there. Obviously, green is good, yellow is caution, and red is bad. The intention of this system is a couple of things. First, we're going to identify those patients with our predictive algorithms that are going to fall into one of the condition buckets. Then we're going to be able to calculate with our measures framework, calculate whether or not they're going to qualify for a measure in that category. And if they are, we're going to flag them on this dashboard. So if you see the visit identifier all the way on the far left there with a circle around it, I have circled the patient here, and they are qualifying for an HF measure, a skip measure, and everybody qualifies for immunization, so we only display them on the dashboard when an immunization, when they qualify for another measure. And the color coordination is green is good. This patient's qualifying for this measure. We've received all the data associated with the measure, and you are going to pass the measure. There's no need to look at this patient. We've just got them on the dashboard to let you know they're going to be part of your data set. Yellow is we've received information, but that information is incomplete. It's not that you have bad data, it's that there's no data. We are expecting information and we don't have that information, so there's some sort of task that's necessary. And red is we've received information, but as results, you're going to fail the measure. For whatever reason, you're not going to be passing the measure. And we're going to go ahead and show you what that looks like as a drill down. We're going to look at this patient we've circled here. Now that brings you to a work list, and let's focus on the second one down right there, the skip compliance workflow. That's the second blue bar down from the top. Now, here you're going to see a lot of things, but at the bottom of that you'll see post-op glucose level. And this is a great place where we can illustrate the difference in colors. So if the post-op glucose level was there and not missing, as you see they're missing in this particular case, if it was there and it was under 250 milligrams per deciliter, this would not cause, that essentially would be a green message for the measure. If everything else was there and that was 250, we're going to be green because it has to be under 250 for day 2. As you can see here, it was a yellow, and that's because we have some issues here with missing data. For whatever reasons, we have not collected the data. There's an issue with interfacing, or if there's some sort of a workaround manual system that's been put together. For whatever reasons, we do not have this piece of information. And it would be red if we received, for example, with the glucose, if that post-op glucose day 1 was 300, we'd immediately send a red flag, and we'd send an alert to the appropriate person, because 300, if that glucose level maintains, you would then fail that measure, and the flag would be thrown. The alert would go out to the appropriate person via text or email, depending on how the customer configured the system, and notifying that action would need to be taken for this particular patient. So we've moved on to the end here. If anybody has questions, we're happy to field them at this time. What you need to do is go ahead into the questions box on your screen there on the right-hand side in the control panel, and let us know if you have something you would like to see. Let's see here. What do we have? I'm going to let some folks type in a few of those. Stand by. Okay. We have a question here. What products or vendors are providing the HIS data warehouse? So I guess this would go to Brian.
Yeah, I guess that's a question for me. The HIS data warehouse that we're using is Siemens Decision Support System, which in some ways is going to be rebranded as Healthcare Intelligence over at Siemens, but the technology that's underlying is the same thing. The DSS product is what offers their clinical intelligence data model.
Great. Let's see. I've got a couple of folks asking about a live demo. You can always request a live demo at our website at spectramd.com. There is, in the upper right-hand corner, request demo. Just type in your information, and we're happy to reach out. But we'll try to keep your information also live here. We can reach out to you if you've typed that in, and we're happy to reach out to you on that. Okay. We have a question here. How are the patients being populated into the population? I'm not sure if you can clarify that. Well, I'm going to take a stab at that. I think this is going to be a Carl question. And Carl, maybe I can frame that as I assume it's how are the patients getting onto the work list, and I'm assuming that's a predictive algorithm question.
Yeah, I believe that in fact is what it is. There are a number of elements, and again, that's a proprietary algorithm, but there are a number of elements that are being used for each disease state. Right now it's working with CHF, but there are values that help us predict that this is somebody that stands a greater chance of readmission. One of the obvious is they have been readmitted in the past, so that's something that goes into the score. But yeah, you're right. It is exactly that, the predictive algorithms. The other piece of that would be in your newer tool, the core measure tool, and what would be those cases that would fit into the study. So what qualifies a person to fit into the heart failure case, something of that nature. And again, those are the criteria that have been set by CMS. And if you're able to identify Medicare patient over 65, those kinds of elements are used to feed the algorithm. That's my assumption.
Okay. There is a question here. Whoop. Does this system start when someone is admitted or when they are in the emergency department? I guess, Carl, I guess that would be you. How are you folks using it today?
Well, at this point, it's based on an admission. The admission order is written and the clock starts. That's something that we have been discussing. Is there an opportunity to be able to start the clock sooner? That's going to be a challenge, and I know we're, as Brian pointed out, we have a number of different computer systems in place, and I know we're working on the emergency department, kind of coordinating the emergency department computer system with the inpatient system. So we're anticipating that may be able to help start it. If we can start that system as soon as the patient hits the doors, obviously that would be optimal. But then you need to be, all the other elements that go into the algorithm need to be in place. So pretty much, in addition to admission, it's whatever the elements that are part of the algorithm. I mean, if it's a lab test, clearly without the lab test being admitted, you have to be admitted, and the lab has to give a specific value in order to be able to set the algorithm in motion.
Great. Thanks, Carl. And just so to clarify, there was a question, and that data, as it flows through the center state system through DSS or whatever other interface that we've set up, flows directly into Focus. There's another question here for you, Brian. Does the Siemens system manage getting and managing, let me see if I can paraphrase here. Does the Siemens system manage getting and managing the unstructured data that you're incorporating into your analysis? I think the question is the manual, you alluded to manual data. I think the question is, how is that getting into the system? Is Siemens helping you with that?
Well, is it a question of the manual data, or is it more of the unstructured, like the radiology results and cardiology results we were talking about?
I think that's it surrounds that particular field, because that was where the discussion centered.
Right. We've kind of attacked that in two ways. Some of it we've done internally in-house, through our integration into the data warehouse, where we kind of look for key phrases and that type of stuff. And On the Spectra MD side, they do some of that for us as well. So it's kind of a mixed bag as to which place it's done in. It's kind of where it makes more sense. But we've had some success with that, both doing it ourselves and really the focus agent doing some of that for us.
Okay, it looks like we got time for about one more here. Okay, what does the score value represent? I think it looks like they're talking about the readmissions risk score. I saw a 15, for instance. What is the scale, and is it gender specific?
The scale that we're using is predicated on the LACE readmission risk score. And I do believe gender is a component to that. I mean, LACE I think that is a public domain tool, but it's LACE is the acronym, and I apologize, I don't know what that acronym stands for right off the top of my head. But I believe gender is one of the components to that tool as well.
Very good.
That's one of the positive things, is we're able to actually utilize a tool like that in an automatic way.
Okay, that's it for today, folks. I really appreciate you attending. We had actually record attendance for those folks that are still with us. We had well over 100 attendees today. I want to thank both of our presenters for the fantastic job they both did. And if you folks have any continuing questions, please feel free to reach out to us at spectramd.com. And there'll be a survey following this. We'd love to have you fill it out for us. You take care, and have a great day. Bye-bye now.